Hi, it's John Snyder again, 12:30 on a Thursday, beautiful Thursday afternoon here. Another edition of Newton-Wellesley Medical Group Lunch and Learn. Today's topic, new treatment options for urinary and fecal incontinence. We're happy to see Dr. Niraj Kohli here with us from the Department of Urogynecology here at Newton-Wellesley Hospital. I've been referring to Dr. Kohli for many years, and his care has been always excellent, so we're glad to have him give us this talk. Next one, Niraj. There we go. Just upcoming lunch and learns. We have one next week. Dr. Garcia is going to talk to us about epilepsy. And then we are taking the school vacation week off. So just mark your calendars that we won't be here that Thursday. As a reminder, these talks are all recorded and they are posted up on YouTube. We also now have a spot on our intranet, which is called Newton, nwh.org/intranet. We'll get you there. And you can, that'll take you right to the link on the page of YouTube and you can see all our talks there if you missed one. Next slide. Just want to promote our orthopedic walk-in that is now open, 978 Worcester Street. No appointment is needed. It's a complete walk-in service, Monday to Friday, 8 p.m. Your patient busts their knee on the soccer field or the volleyball court, and they don't want to go to the emergency department and they want to be seen by someone in our sports medicine department. They can walk in, 978. We have x-rays, casting, bracing, everything available. Next slide. Next slide. And then just to promote our physician wellness programs, folks have seen this slide before. We have 5 active programs right now that we'd love for you to take advantage of. The Physician Care Concierge is a free program. You sign up and you ask them any questions and they will find you solutions. It's great. You can just sign up by going to communitycircles.com, community.circles.com, and use the welcome code NWH. You get a free year. And the services range anything from who's going to clean my gutters right now because they're full of leaves versus how can I get the best gift for my wife? All these things, you're welcome to use these services. They're at no cost to you, and they recommend some great recommendations. Also, we have a weekly virtual meditation class. That's on Thursday at 5:30. Our Peloton membership program is still there. You can get one full free year of Peloton membership where you can do anything from ride a bike, run outside, walk inside, do meditation, yoga, strength training, core training, and so much more. That's free to you for a full year. Please take advantage of that while funds still last. We have an online coaching and physical training program that's done with our staff over at Shipley Fitness Center, and Daniel Destin runs that. You can contact him directly. And then we have a drop-in virtual yoga class that's available as well. Next slide. And take it away. Thanks.
John, thanks so much. And I really, really appreciate everybody taking time out of their busy schedule on a Thursday afternoon to join us. I wanted to talk today about new treatment options for urinary and fecal incontinence, which is near and dear to my heart. And probably you're seeing it in more and more of your patients as this becomes increasing quality of life conditions. Firstly, I did want to introduce you to the Boston Urogyne team. I'm blessed to be working with some of the best people in the business. We are located on 70 Walnut Street, right around the corner from the hospital. The office number, I'm sorry, it's 340-6446. That's a typo. And my cell phone is here also for your access, so feel free to call me anytime if you want to discuss a patient or a referral. Sarah is our office manager, a long staple at Newton-Wellesley, and we were lucky enough to recruit her for our office. Kristen Shaw is an outstanding physician's assistant who takes care of many of my patients and does many of the procedures in our office. Sandra Patton is a medical assistant who has been with me for over 15 years during my days at the Brigham. And Candace McCall is our new recruit who's phenomenal with patients and is also doing urodynamic testing for us. So we're all here to help you and your patients. In the interest of disclosure, I have no disclosures to report regarding the content of today's talk. Just as a way of an introduction, as a urogynecologist, we deal with all aspects of pelvic floor dysfunction, but specifically urinary and fecal incontinence, overactive bladder, and prolapse. We are seeing more and more pelvic pain as well. So if you do have pelvic pain patients that have not improved with traditional techniques, we're happy to evaluate them. But our real mainstay is urinary fecal incontinence and prolapse. And this affects over 25 to 50% of all women. And fecal incontinence affects 6% of young women, mostly related to childbirth issues, and 15% of older women. These numbers are probably underreported and probably are much larger than stated, and they do increase with age. And women are 10 times more likely to suffer from these conditions because of certain normal life events, including childbirth and menopause. So it is a very prevalent condition in women as they get older. And it's a quality of life condition, which is becoming increasingly impactful, and patients are desiring proper diagnosis and treatment. I think what's really exciting is some revolutionary changes over the last decade in our diagnosis and approach, resulting in better success and safer treatments, which is what I wanted to share with you today. So the treatment algorithm for stress incontinence, which is typically cough, sneeze, laugh, lift, leakage, has traditionally been behavioral, teaching patients pelvic floor exercises or referring for physical therapy. Just a plug, the physical therapy department at Newton-Wellesley over the last decade has increasingly become very expert at the treatment of pelvic floor dysfunction with the introduction of Rebecca Stevenson, who was previously at Brigham and Women's. So I would strongly encourage you to refer to them if you have any pelvic floor physical therapy needs. Traditionally, it was either physical therapy or surgery, and there was nothing really as an in-between for patients. And although our surgeries have evolved, over 150,000 surgical procedures are performed annually for stress incontinence. And in the right hands with the right patient, the suburethral sling is a safe, minimally invasive, and effective procedure, which can generally be performed in under 30 minutes on an outpatient basis. The downside of a sling is that it is operator dependent. So clearly, hopefully, the operator has experience in performing and managing those complications. But regardless, it still requires a hospital visit, anesthesia, and a post-operative recovery. And that recovery oftentimes will be avoiding heavy lifting, straining, sexual activity for 4 weeks. And that sometimes is difficult if you have young children at home or your profession or your personal activities require you to lift and strain. Not all patients are candidates. Ideally, if you're postpartum and you're still planning on having more children, we would typically not offer a surgical option because subsequent deliveries may affect the results. And so those patients are often relegated to very conservative therapies. And then there's also the question of management of postoperative complications, and specifically mesh concerns and complications, which many of you have probably been hearing more and more about in the media, as well as the medical legal arena. So bulking agents for stress incontinence have actually been around since the early 1900s. And typically, they were generally advocated by urologists as first-line therapy, and typically advocated for intrinsic sphincter deficiency. The urogynecologists and the gynecologists typically would offer Birch procedures or now slings, but essentially the procedure is injecting a material to help close the urethral sphincter and cause the leak point pressures and the incontinence to go away. And since the initiation or introduction of this technology, a variety of injectables have been used, including paraffin wax, carbon pellets, macroplastique, collagen, coaptite. Unfortunately, past injectables had a low cure rate and a high rate of repeat injections and significant complication rates. And although they were easily performed in the office, their variable success rates and higher than acceptable complication rates really precluded widespread adoption and recommendation. Most recently, there's been a new kid in town called Bulkamid. And this is basically, I think, a revolutionary new material and injection system, which is essentially composed almost of 98% water and 2% of polyacrylamide, which is a biologic polymer. And the way I describe it to my patients is by adding starch to your gravy, it thickens it up. And that's exactly what happens when you add this small amount of polyacrylamide to water. And when you inject it, it's very soft and biologic, almost like a breast implant or silicone. It's a soft homogeneous gel, and it's used to close the internal urethral sphincter. And this is actually the kit that has 2 vials of the injecting agent, 2 small injection needles, and then a small disposable telescope system where we go in the office and we actually visualize the urethra. And we inject this bulking agent on both sides of the bladder neck and literally cause it to close. Over 70,000 patients have been treated in Europe, mostly as a response to finding an alternative to sling mesh, which was causing complications. And in the 10 years that they've been studying this material, there's a 75 to 85% success rate with no long-term complications. In our practice, the procedure takes literally about 5 minutes. The patient comes in 30 minutes in advance. We inject some local anesthetic in the periurethral area and we let it sit for about 20 minutes. And then the injection is actually done on using a video display so the patient can see what we're doing. But what's really remarkable is that the way we do this procedure, we've confirmed stress incontinence prior to the procedure, and then they come in, we fill their bladder, and they leak. We then do a series of injections. Most patients will require 1 to 1.5 vials. On occasion, they might just have 1 vial for use or 2, but we inject until they no longer are leaking. So with the bladder full, after the injection, we'll actually have them stand up and see if they still leak, and the leakage should be gone. If they still leak, we'll inject a little bit more and titrate to dryness. And then finally, we have them empty before they leave and can ensure normal voiding. What's remarkable is that there is no recovery. So it's a short office-based procedure under local anesthetic. The studies so far from Europe have been shown that it's safe, effective, and durable. There's really no need for a hospital visit or anesthesia, and there are no postoperative restrictions. Essentially, these patients can go back to their activities on postoperative day 1. The last group of patients we had, many of them were shopping, gardening, or playing tennis the next day. The other nice thing is that over time, if the patients need additional injections, they can perform this. And it also does not preclude the patient from other treatment options. So this patient or a patient who elects to try this, if they're not happy with the results, they can still do physical therapy. They can still have a sling put in as an additional procedure. So who's a candidate for Bulkamid? Well, any woman with bothersome stress incontinence, regardless of age or body habitus. So for those patients who are of an advanced age or who have a large BMI and you're concerned about anesthesia or risks of surgery, they're ideal candidates. Any woman who wants a safe and effective office-based procedure, women who want to avoid major surgery, hospital visits, anesthesia, or postoperative recovery. We have many women now who want to avoid mesh use given the media spotlight on mesh complications. We also have women who still have bothersome stress incontinence after any kind of incontinence surgery or sling removal or even physical therapy. And then finally, I think one of the greatest potentials is really for those women who have not completed childbearing. So typically those women who have stress incontinence after a delivery, whether it be near term or remote, and still want to have children, typically did not have many good treatment options, but now they can come in for an office-based injection and then and still have more children and then have further injections if needed. Also, this is covered by insurance. It qualifies under the treatment for intrinsic sphincter deficiency. We've really found universal coverage on all of our patients. So I want to switch gears a little bit and talk about overactive bladder and urge incontinence, which is probably something you see in your practice very often, especially if you're screening for it. So the old terminology used to be detrusor instability or urge incontinence, but the new condition is overactive bladder. And it's characterized by patients coming to say that they have urgency frequency with or without incontinence, and this frequency may be daytime or nighttime. Typically, the treatment has always been behavioral. Again, physical therapy can be very effective in some of these patients, and then mostly pharmacologic. And the pharmacologic treatment of overactive bladder has developed significantly over the last 20 years. Traditionally, we tried oxybutynin, and then one of the most original bladder-specific medications was Detrol or teltaridine. There's now a whole host of different medications. They all operate as an anticholinergic, and they have the associated side effects of anticholinergic use, which we'll talk about. Mirabetril or mirabegron, which is a beta agonist. So rather than causing bladder relaxation, it actually promotes relaxation of the bladder on different receptor levels and therefore doesn't have those side effects. I will do a shout out for Ditropan transdermal, which is oxytrol. As a primary care, I think it's a great place to start for patients. It's an over-the-counter patch, which is used twice a week, available at almost any retail chain. And because of its safety profile being used transdermally and having a steady state level with better bioavailability, it does not require a prescription. And it's a real nice way of starting patients on an anticholinergic, which is convenient and avoids the first pass effect of oral medications. The problem with overactive bladder medications is the efficacy in most studies is approximately 50%, and only 10 to 20% better than placebo. Also, the main problem is really the 70% discontinuation rate that most studies have shown within 12 months. And this could be a combination of lack of efficacy. Some patients have an accommodation response to the medications where they work initially and then over time slowly have decreased efficacy. But most commonly, it's the side effects. So many of these patients will have dry mouth, vaginal dryness, which is significantly bothersome in those patients who already suffer from menopause and genital urinary syndrome of menopause. The other is that they're commonly associated with constipation, and therefore with dry mouth and constipation, oftentimes patients end up drinking more, which then worsens the overactive bladder condition. Cost is an issue, especially of the mirabegron, which is generally not covered as a first-tier medication. And then most importantly, I think it's poor follow-up. We always have to basically start patients on medications and then follow them closely, do dose adjustment, assess for risk factors, and offer patients alternative therapies when necessary. The one important data point that I wanted to share with you is that recent data suggests that there's an increased risk of cognitive side effects in patients over the age of 65 after only 3 months of use. So although these medications are often used on a chronic basis in many patients, I would definitely be careful about using chronic long-term use in patients age over 65. There's a 21 to 65% higher odds of dementia. We've also seen decreased memory, decreased focus, concentration. And so I think this is really important when you're deciding on medications for the elderly patients. Luckily, the AUA guidelines for overactive bladder do recommend that third-line therapies can be offered to patients if they cannot tolerate anticholinergic medications or they have non-responsiveness. And the two most common are bladder Botox injections and sacral neuromodulation. Commercial payers will often require a trial of 2 or more medications before approving third-line therapies. And then the third-line therapies are effective and durable for refractory as well as primary overactive bladder. So if we do have patients who may not be good candidates for anticholinergic medication due to side effects or lack of efficacy, we're pretty aggressive about going to third-line therapies due to their success and low risk. So Botox, many of you have probably seen patients who've had Botox for overactive bladder. We've been doing it for approximately 15 years. Over the last 5 to 7 years, it has been FDA approved and is now currently on label, as well as covered by insurance. The Botox is essentially injected into the bladder muscle via cystoscopy, and that can be done in the office or the OR. Generally, we use 100 units for idiopathic overactive bladder and 200 units for neurogenic. The higher the dose, the more efficacious will be the response, but also the higher risk of side effects. And those side effects can include voiding difficulty, incomplete emptying, need for a catheter, or urinary tract infections. In those patients who are neurogenic, most patients are already catheterizing themselves, and therefore we want to remove the overactive bladder component, so the higher dose is acceptable in those patients. It is literally a 5-minute procedure. We go in with the cystoscopic telescope and a special needle, and then we inject the Botox, which is diluted in normal saline and stained with methylene blue. And the reason is when we do the injection, we can see exactly where we've injected, so we don't repeat areas of injection and give the patient the best response. And essentially within 2 to 4 weeks, 80% of patients will see a significant improvement in their overactive bladder symptoms, including urinary incontinence. And the results of Botox will last anywhere from 3 to 12 months. So the Botox irreversibly binds to the receptors on the bladder and therefore prevents the nerve synapses from causing hyperspastic bladder spasms. Unfortunately, those receptors will recycle typically over 3 months, and the new receptors no longer have the Botox, and therefore most patients are committed to regular injections at variable intervals. But it is ideal for refractory overactive bladder and those who have side effects with overactive bladder, as well as elderly patients. My oldest patient we've done is 95 years old, who had really bad overactive bladder and nocturia. And literally 2 weeks after the injection, she was sleeping through the night and not having to go to the bathroom as often. This is a randomized trial comparing anticholinergic to Botox, where they looked at Botox 100 units. And what they found, the crux was that there was a twofold higher likelihood of complete resolution of the urge incontinence. There was slightly a higher urinary retention and UTI rate, but there was also definitely less dry mouth. So some of the advantages, it is a safe and effective procedure. It's easily administered. We typically do it in the operating room just because of the efficiency of the operating room at Newton-Wellesley, as well as the patient comfort issues. It's a quick onset of action, and there's really no significant contraindications, but we're careful about screening patients so that they don't have pre-existing voiding dysfunction or recurrent UTIs. If they do have those conditions, we typically would prefer to seek another alternative third-line therapy because the Botox could potentially worsen their pre-existing conditions. The disadvantages, the quoted literature is 5 to 10% risk of UTI or postoperative voiding dysfunction. In our hands, we find this in less than 2% of patients, and it may be due to either technique issues or patient selection issues. Again, a limited effect of 3 to 12 months. Patients should be counseled that they may need a repeat injection based on recurrence of their symptoms. It does not have any effect on any other pelvic floor dysfunction, i.e. Bowel-related symptoms. So one of the other intriguing third-line therapies, which has seen significant development over the last decade, is sacral nerve stimulation. This is a procedure that was first introduced in the early 1980s, and over 300 implants have been performed worldwide. We're very lucky because our patients in this country have significant access to this technology and its significant benefit with limited side effects. In Europe, because of the cost and the complexity of the technology, they have rationed many of this, and they have a certain amount of procedures that can be performed yearly, and then physicians have to decide which patients they would select for this. I didn't put the video in because I didn't know if this would translate online, but the SNS implant technique is a two-stage technique. The first stage is performed with the patient in the prone position under IV sedation local. We mark the bony landmarks based on a fluoroscopy x-ray, and with local anesthetic, we put a tiny wire or lead into the S3 foramen. As many of you know, the S2, 3, 4 is the primary innervation of the pelvic floor, including the musculature, the nerves, the bowel, and the bladder. And so we will do approximately a 20 to 30-minute procedure where we put a tiny wire in the S3 foramen and confirm response. And then the patient actually goes home with a remote control, and she can actually try the sacral nerve stimulation for 2 weeks. And if she gets a good response, which we define as greater than 50% improvement in her pelvic floor symptoms, then she is offered the opportunity to actually get the implant. And the implant is essentially a pacemaker. And the way I describe it to my patients is that your bladder is having spasms, and we want to control these spasms using a pacemaker similar to the abnormal heartbeats and arrhythmias. And the SNS indications that have been approved are urinary urgency and frequency, urge incontinence, non-obstructive retention, and fecal incontinence. As a side note, we have found that interstitial cystitis, chronic constipation, irritable bowel syndrome, and pelvic pain syndromes are also showing significant benefit using this therapy, but not as a primary indication. So just a quick note, this was the INSIGHT study, which was sacral neuromodulation versus standard medical therapy. And what they found is that sacral neuromodulation resulted in better therapeutic success compared to anticholinergic in those with refractory symptoms. The recent innovations has been miniaturization of the pacemaker, which makes it much easier for patients to tolerate, as well as MRI compatibility and rechargeability. So typically we would use a standard size pacemaker, which then had to be replaced every 3 to 5 years, had to be reprogrammed often. But the new technology literally is a small pacemaker, which has a 20-year battery life, which is recharged using the charging pad at home and is managed with a very simple remote control. Less complications, and the advanced software has resulted in better response long-term. This was a study that they did specifically for this new technology with 129 patients, and they found that 89% of patients were therapy responders 1 year out, and the average urinary incontinence episodes was reduced from 5 daily to 1.4, and significant improvement on all levels of quality of life questionnaires. What I think is really exciting is the ability to treat fecal incontinence. This was a very small pilot study, although much other data has been shown to be effective for fecal incontinence using SNS. And 92% continued to have significant response at 6 months post-implant, with over 50% reduction in their fecal incontinence. So a median of 8 to a median of 1.5, 6 months out. Just to finish up, this has been our experience using the new technology over the last 1 year. 31 patients with a mean age of 67. We had an implantation rate of approximately 90% off the test stimulation, 90% of overactive bladder, and 91% of patients with fecal incontinence reported a significant degree of symptomatic relief. Approximately 90% would recommend therapy to a friend. And now we're currently on track to do almost 100 implants this year. Some of it is upgrading old technology, and many of it is new patients who are seeing the benefit of these new developments. So just to wrap up and leave some time for questions, there's a growing need for safe and effective treatment options for urinary and fecal incontinence. We have some recent advances that make the therapy much more effective and safer. Best results really are from proper diagnosis and patient selection. Bulkamid is an office-based option for stress incontinence, whereas Botox can be used for overactive bladder, and sacral nerve stimulation can be used for overactive bladder and or fecal incontinence. And I think what's really exciting is the evolving technologies, including energy and growth factors, including stem cells and PRP. And I hope to be able to present that to you in the near future. But I did want to thank you all for your support. And if there's any way we can help your patients, we would be delighted. Thank you.
Thanks, Niraj. That was really a nice summary of those three really cool treatments. I don't see any questions in the box. Please feel free to put them in there. I would throw out one question to you, which is something we struggle with a little bit in primary care, which is, before they get to you, trying to distinguish. It's sometimes easy to tell the difference between OAB and stress, but sometimes it's not so easy. And the second question I would say is, are there foods or drinks or things that you tell your patients not to do with OAB that you've found to be effective?
Yeah, great question. So, the simple test is really have them come in with a full bladder and ask them to cough. And if they have stress incontinence, usually that'll show up. If they don't, more likely than not, it's overactive bladder. In addition, if patients are saying that I have urgency, frequency, I can't get to the bathroom in time, that's more consistent with overactive bladder. There are some very short form urine questionnaires, which I'm happy to forward. The ICIQ, which is a four question questionnaire that you can use as a screening test, which can give you some idea. In terms of dietary, when patients first come in, we always do first-line therapies, which is dietary modification, avoidance of caffeine, alcohol, carbonated beverages, and spicy foods, which is typically what we start with. We talk about pelvic floor exercises, which are easy to do, and we have a handout. And again, I'm happy to share any of our resources with all of you. And then we'll talk about fluid reduction as well. Typically 64 ounces of fluid a day is really all patients need. So we always look at that. And then if they're still not feeling better, we progress to second-line therapies, which are generally physical therapy and medications, and then third-line therapy.
And do you have a standard kind of questionnaire that you give folks to kind of rate it? You said, quality of life. Is there a urinary kind of standard care like there is for men with prostate?
Yeah, so we actually use the PFDI, which is really nice. And it's online, but I'm happy to share it with you. The PFDI is the pelvic floor distress inventory, and it actually has subsets, which we'll talk about: overactive bladder, stress incontinence, voiding dysfunction, prolapse, and then defecatory dysfunction. And sometimes we will combine that with the FSFI, which is the female sexual function indicator, and bring that information as well. But the PFDI, it's about 20, 25 questions, and you can actually score it. And again, I'm happy to share that.
Thanks. Dr. Finn wanted to know if you could tell us a little bit more about the chemistry of the Bulkamid. I'm sure he's assuming the gel he wanted to know about.
Yeah, so it's basically a biologic polymer, which when added to water causes cross-linking of the water molecules. It was pretty fantastic. The first time we started it, which was latter part of last year, we did an animal lab. And when you do the injection and you feel the actual injectable, it feels biologic. It's soft. It's not. It doesn't feel foreign. In terms of the actual organic chemistry, I'm happy to get that data and send it to Dr. Finn.
Do you have, do you get any kind of stenosis as a complication ever with that because it's too much or not really?
Yeah, so that's a great question. I think the key becomes is, as always, you want to be careful in those patients who already have pre-existing voiding dysfunction. So if they have neurogenic bladder and the bladder is not contracting properly, you want to be careful with that. But the nice thing about this is that you're really titrating up. So we will titrate till almost closure, and then we'll be on the brink of them having a small amount of leakage and then do a top-off injection. And we always also do a uroflow afterwards. We're very careful also. Any procedures we do, you'll notice that if the patients come into the office, we will most likely always have them come in for follow-up with a full bladder, and we'll do a uroflow just to make sure that the flow rates are fine. Yep.
There's another good question here in the box, which says, what would be the most helpful for those of us in primary care to have tried with our patients before referring to you? It sounds like you were pushing or suggesting Ditropan TDS for overactive bladder.
Yeah, I mean, I think, you can definitely do prescription anticholinergics. And I think in younger patients, I think that's fine. I think a vast majority of patients, if they do a combination of dietary restrictions, pelvic floor exercises, and anticholinergics, many patients can actually get better. Clearly, the earlier you pick these patients up and the more kind of recreational overactive bladder they have will respond better to first-line therapies. And I think that's what I would recommend. I think transdermal is just more convenient for the patient. It's easier and it's probably more cost effective. But any of the anticholinergics are okay, especially in younger patients. I would be hesitant to prescribe them in patients over the age of 65 on a long-term basis. And if you are looking at a long-term medical treatment option, then mirabegron is probably your best option. You might have to kind of jump through a hoop where you try a patient on 4 weeks of an anticholinergic, 1 or 2, before you get mirabegron approval. But even then, sometimes mirabegron can involve a significant out-of-pocket cost to the patient because it's non-generic.
Okay, we're a little over time, and I want folks to be able to start their afternoon on time. Really appreciate you coming and giving us this talk. It was really informative. We'll get this up on YouTube. Everyone have a great weekend. It's going to be a beautiful, at least half of it's going to be a really nice one. So enjoy it, get some sunlight, some vitamin D. We'll remind you, we'll see you all next week, and have a good weekend. Thanks.
Thank you very much, everyone.
Okay, bye.